I'm Adele Gauthier from Breast Cancer Foundation New Zealand, and tonight we're talking about breast cancer surgery, preparation and recovery. Just type any problems you've got in the chat box and people will help you there. Hopefully we're over our problems now. We'll have a question and answer session at the end of the webinar, and we hope we'll get to all your questions. Don't worry if you don't keep up with what's going on. We will be posting this online and you'll get a link sent to it via email. So, talking about breast cancer surgery, as we said, that's where most of you will start in your breast cancer treatment journey. And often it's pretty soon after you've been told you've got breast cancer, there's a ton going on and a ton of information coming your way. Tonight we're going to help you understand why your surgeon has recommended the treatment that you're going to be having, some of the associated procedures like sentinel node biopsies, what happens after the surgery, and how you deal with some of the complications that hopefully won't but might arise. We have three panellists sharing with you tonight: Michelle McAteer-Ross, breast surgeon Dr. Richard Hammond, and nurse Kylie Kitchen. First, we'll hear from Michelle, who was diagnosed with breast cancer last year at age 51. Michelle, tell us a bit about your diagnosis and what your experience of surgery was like.
Okay, so it was about the end of September, beginning of October last year when I was lying in bed and felt an itch on the underside of my left breast, and I could feel the lump. So followed up with a GP appointment the following week. They then suggested I go and get the mammogram and ultrasound, which I did the following week. I had to go back in the next day and get a biopsy on both the tumour and on my sentinel lymph node. The following week I went back to see the breast surgeon and was told that I had cancer, which, as a lot of you will know, is a bit of a shock, to say the least. I also was booked in for surgery the following week, so I had to get bone scans, CT scans, blood tests, fill out all the forms for the hospital, all in a very short period of time. I then, probably the worst time through all that was waiting for my CT results to see if the cancer had metastasised or not. That was a pretty stressful time for both myself and my family. Also hearing during the time that we were told that I had cancer about having to wear a wig was a big thing for me, as well as, sort of losing my hair was quite a big step. Moving on to the surgery, I had the following week. It was a partial mastectomy that I had, and everything went fine with that. There was no pain, little to no pain, and I came out of the surgery wearing one of these. It's basically a compression binder, so I couldn't actually see a lot of what had gone on until the next day after coming out of hospital. I only had one night stay. And then the following day, the district nurse came round at home and took my binder and the dressings off, and I got my first look at the surgery, and I was really expecting like a shark bite out of my breast, thinking it was a partial mastectomy, and I was amazed that she'd done such a fantastic job, and it was just basically looked normal, had a scar, but other than that. During the surgery as well, I had 28 lymph nodes removed, which 14 had cancer, so that was quite a shock. We knew going into my surgery that it had spread to my lymph nodes, but we didn't know until after my surgery just how much it had spread, which was significant, obviously, with the 28 being taken out and 14 with cancer. With the surgery, of course, I ended up with a grenade drain, which is a little I think Richard may be going into that a little bit more, but a drain that you have after surgery. And I had a portacath, which I've actually got one here. You probably can't see it that well, but this was a portacath that was put in to just up over here, and that's where all my chemotherapy going into that was put into, and that saved it going in through my hand or whatever. So I've obviously recently had that taken out, so that's there. So just after the surgery, was trucking along basically, and went for my follow-up appointment and to get my drain out. And I was starting to feel a little bit funny that day, but nothing too much. The surgeon saw that there was possibly a infection starting, so I was given some oral antibiotics to start. Had the drain taken out, and then by the time I got home that afternoon, I was very sick. I had the shakes, felt awful. I'm not somebody that dissolves in tears too often, but I was very upset. That later on that night, I took some pills and had started the antibiotics. Later that night, basically that popped, I suppose you should say. It was horrible as it was. I was covered in lymphatic fluid, so raced off down to North Shore Hospital and got admitted and found out that I had a Staph aureus infection. The following day, the surgeon came round and I was told to get IV penicillin and flucoxetine 6-hourly and to get a ultrasound to see if there was any fluid left in me. All they could pick up from the ultrasound was a small seroma just under my left nipple, and other than that they couldn't find any more fluid. So this was Friday, so Friday, Saturday, Sunday. And then Monday I was on the IV antibiotics, and by this stage my arms were starting to tissue because I couldn't have anything on my left arm, so everything was going through my hand and arm, and so I was starting to get a few problems with the amount of antibiotics I was having. The Monday morning I went and had another ultrasound to see again, because it hadn't cleared up as well as what they had expected. So I had another ultrasound and still no fluid was showing up other than the small seroma. Luckily, I had a previous appointment back to the breast surgeon, which was across the road, and as soon as she saw my wound, she knew that I still had a lot of infection, and managed to drain all the infection, I suppose, out of me, which was actually quite significant. So we were a little bit perplexed as to why it hadn't been picked up at the hospital. Went back to hospital with a letter showing exactly what she had done in her room, and carried on for the next 24 hours on the IV before getting let out the next day. Unfortunately, I was due to travel to Fiji for a family holiday on the Wednesday, and we had to postpone the trip until we sent the kids off, but my husband and I stayed back until the Saturday before we got to go over. The trip to Fiji was odd because I wasn't allowed in the sun, I wasn't allowed in the water, so it was and I was very worried still about the drain, although the second drain had been taken out. It was still...
But you got there.
But I got there, yes, and it was still nice to be somewhere else rather than be at home. So following on from that, once I got back from Fiji, I ended up with another infection and had to get keep getting it drained out as well. Aspired, I think is the right word. So aspirated, that's the right word, Richard. Handy having a surgeon right next to me. So after all the surgery problems and things that I had, the other treatments that I had to have was chemotherapy, radiation, bone therapy, my hormone therapy, which is extemestane and Zoladex injections every month, which I'm still having. I have regular lymphatic massages because of the amount of lymph node involvement, and where the compressions bleed whenever I remember to. I've also just been accepted for a clinical trial as well, so I'm pretty rapt about that. The symptoms that I probably still have are a bit of numbness at the wound, which is quite understandable, a bit of numbness in the toes from the chemo, and I've had a little bit of cording. But other than that, it's been, pretty good.
Wow.
Yeah.
After all that.
Yeah, a lot going on, but...
Yeah. Well, thank you, Michelle. Thank you so much for sharing that with us. Now we're going to hear from Dr. Richard Hammond. Richard's a member of our medical committee here at the Foundation, and he's a breast surgeon working at North Shore Hospital in Auckland and also in private practice. Richard, tell us about the kinds of surgery people out there are going to be having and some of those little complications.
Sure. Thanks, Phil. Thanks, Jill. It's very interesting. Certainly had a lot going on when you got diagnosed. So I've got a slide there that should show the choices that women have when they are diagnosed with breast cancer. And really, to simplify it, there are two choices of how we deal with breast cancer. That's either a partial mastectomy, like you had, or lumpectomy, which doesn't sound quite the same thing, but lumpectomy doesn't sound quite as bad, or a full mastectomy. And we decide, together with the patient, what the best treatment is. But ideally, for breast cancers that are smaller, we can do a partial mastectomy or lumpectomy. And those that have only one cancer in the breast, we can do a lumpectomy. And if we treat a breast cancer with a partial mastectomy, they've got to have radiotherapy as well to sterilise the rest of the breast tissue. For women that have multiple tumours in their breast or large tumours, then really we can't preserve the breast sensibly without removing a lot of breast tissue, and therefore will leave too much of a deformity. So we then have to do a mastectomy. And if we do a mastectomy, we don't usually need to treat the rest of the breast with the breast is gone, so we don't need to treat that with radiotherapy. So those are really the two choices. Of course, when we do the partial mastectomy, the majority can be done quite simply with an excision of the lump if it's small, and then we can just bring the breast tissue together. We are now doing more women, we're treating more women with partial mastectomies by doing some partial breast reconstruction, new techniques that have come through, and these are called oncoplastic techniques where we move the tissues around a bit more. So we can remove more bigger tumours, still doing a lumpectomy or partial mastectomy. And this is a sort of a new phase that's come. It's really quite exciting for breast surgeons and also for women because they're getting better results there. When we do whole breast reconstruction, that's done after a mastectomy, and there we can do reconstruction through many different ways. We can use your own tissue, or we can use implants. So those are the sort of cosmetic things. If we're doing, for a lot of tumours, we can't feel the tumour. So if we can see there on the slide there, you can see a mammogram with a wire going into it, and that is, at the bottom of the wire there is the little cancer there. And what's happened there is we've removed the tumour, and you can take an X-ray with the tumour at the breast tissue and the tumour out of the breast, and that's called a hook wire excision or hook wire partial mastectomy. And that's how we remove tumours that we can't feel. So these are tumours that are not like your one that was palpable, but the ones we can't feel, this is how we find them. And that's what we call a hook wire guided partial mastectomy. And then we can reconstruct the breast however we need to, depending on the amount of tissue that's removed. If we move to the next slide, I'll just explain sentinel node biopsy, because you didn't have this though, Michelle, because they could do the tumour was already palpable and you had something in the lymph node. But for most people, we don't know if there's any tumour in the lymph node, since we do what's called a sentinel node biopsy. And this has been around now, technique been around for about 20 years. When I first started back in practice as a consultant, it was just kind of beginning. And before that, everyone used to have an axillary dissection, whether we knew they had positive lymph nodes or not. So it used to be, as young surgeons, we were removing 20 lymph nodes.
So axillary dissection,
that's taking all of the lymph nodes.
Right.
So what we then moved to is this procedure now, which is a sentinel node biopsy, where we inject some particles around the tumour or into the breast, either blue particles, a blue dye, or a radioactive colloid. And those particles go via the lymphatic system, which you can see on the screen there, to the first lymph node that the cancer may have spread to. So we don't know if the cancer spread there. We just take that lymph node out using that technique. And instead of taking 19 negative lymph nodes out, we just take 1 or 2 out, and we see if cancer's in there. And that allows us to stage the patient as to what other treatment might be needed and whether they need any further axillary surgery. So if the lymph nodes are positive, we may then go on and do an axillary node dissection, or if you have cancer in the lymph nodes already, like you did. We went straight to an axillary dissection. But if there are a lot of lymph nodes involved, what we do is we remove the majority of the lymph nodes under the armpit. So basically from the vein downwards, and we clear that area. And often it's about 15, 20 lymph nodes removed. And in doing that, you will also lose some sensation on the inside of your arm because nerves pass through that area. You shouldn't lose any of the ability to move your arm, but you will notice some sensation there. And you can get pain as well from it because we've divided through some of the nerves that supply your skin that come through that area. And that can't really be avoided. But obviously we're trying to avoid axillary dissection as much as we can. In fact, there's been a recent move, even if you've got 1 or 2 lymph nodes positive on your sentinel node biopsy, that we now are giving more radiotherapy rather than doing no treatment rather than doing axillary node dissection. So we're actually minimising the amount of treatment you need and the amount of surgery happening all the time. So if you've had an axillary node dissection, then you'll need a drain put in, which is what you had. So the drains we put in generally are a little bit bigger than when you come out of surgery. That's a little grenade drain that you'd go home with, but the drains you wake up with would be sort of a little flask like that, and that's to drain away the blood and the serous fluid from where we've operated. And then we have to leave that drain in under the armpit because you're going to have ongoing lymphatic fluid. And the lymphatic fluid is like the fluid when you raised your knee as a youngster, and that yellowy fluid, and that's coming out of your breast tissue and into that area, and we have to drain it away, because if we don't, the fluid will build up. And if we leave that, and you can get the bugs in there, you can get an infection, which is what can happen. And so that's why we need a drain. We also use drains in the breast sometimes, especially under mastectomy scars or when we've done reconstructions of the breast. And we also do it when we just had a mastectomy without leave it under the skin flaps. So they may stay in for 7 to 10 days and then generally come out. And sometimes if we remove them a bit too early, we've got to keep doing drain. We've got to come back to the clinic and we've got to stick a needle in you and drain that fluid off because we can't leave it in there. So that's what can happen sometimes. Have I finished?
No, a little bit on the complications.
Oh, okay.
My screen.
Yep. Okay. So it's not printed out. So some of the complications, I'll just look at what I was supposed to that can happen after surgery. So I could probably divide those into sort of immediate. I can't read that. It's a bit smaller. So if we divide them into immediate complications and delayed complications. So obviously after we've done any sort of surgery, you can get bleeding. Putting a knife into people that can cause bleeding. We try and stop that, but sometimes it can happen. And there is an incidence of people who are going to get some bleeding after their surgery. And probably maybe about 5% of people might have a little bit of bleeding. And sometimes that means you've got to go back to the operator. It'll be internal bleeding from where we've operated on the breast or under the armpit. We have to go back. But something the drain can't deal with, and we have to go back and take that out. Because if we don't take the bleeding out, it'll get infected and cause an ongoing problem. Then we can get infections. Again, happens in about 5 to 10% of people having breast surgery. We always give antibiotics during surgery, but sometimes an infection will still develop. And then the other main problem we have when operating on the breast, we can get nerve injury, and that's what I talked about briefly before, is where the nerves that are coming out through under the arm there get injured, and there's chronic pain can result in that. And that's if the nerve has been injured in some way or just been a bit overstimulated, and it generally will settle down, but sometimes needs some intervention. And then we have the delayed complications, and they are largely things that lymphedema is a big one, especially if you've had an axillary dissection and radiotherapy, because that is stopping the lymphatic drainage that's coming up your arm. That flows through the same lymph nodes and everything that we've operated on. So we take those out, you get a build-up of fluid behind that. That happens if we just do a sentinel node biopsy. That only happens in 1 or 2% of people. Axillary dissection, more, maybe 5% of people, and in very few is it really becomes very severe that you've really got a bad problem with swelling of the arm. The other main, another complication that's chronic is obviously having a cosmetic complication that doesn't look too good, and you want to have that corrected, but that's usually a secondary procedure that can be done.
That's the look or the shape.
That's the look of the shape of the breast or the after we've done a reconstruction, and sometimes that needs many operations to fix it if you've had a reconstruction. But again, not too many patients have that, but it's something that can happen. And then you've got things like if you've had a reconstruction where we've used your own tissue, you can actually lose that whole implant, the whole of your own tissue. The reconstruction can die. That's again very rare. Or you could lose if we have a silicone implant in the breast, you could lose that as well. And again, not a nice complication, and it happens rarely. But it is something that needs to be considered when you're making your choices about some of these treatments. Yeah. That's all we just talked about at the moment, but happy to answer any questions, obviously.
No, that's good, and we are getting questions through, so we will come to those later. Thank you, Richard. That was extremely informative. Now we're going to hear from Kylie Titchens. She's one of our nurses here at Breast Cancer Foundation. If you've ever phoned our nurse line, chances are you might have spoken to her even. She's worked in breast surgery and recovery in the past, and so she'll be talking about post-operative care, including how to deal with some of those complications. Kylie, go for it.
Thanks, Fidel. So tonight I'll give you an overview of your surgical journey from when you wake up in PACU, also known as recovery, and right through to your discharge home. I'll also touch on the main points of post-operative care, and I will also share some useful tips from breast cancer patients themselves, which I have gathered from our Breast Cancer Foundation New Zealand MyBC online community. So first of all, throughout the hospital journey, you'll start, when your operation is complete, you'll wake up in PACU. So PACU, or the recovery room, is a safe environment where you will recover from your anaesthetic and your surgery itself. The nursing ratio is 1-to-1, so you're closely monitored with a range of monitoring equipment. You'll notice various lines, IV lines and tubes that you'll wake up with that you might not have had prior to going to sleep. First of all, you have your intravenous line, so that's the IV drip which your anaesthetic goes into. You also get your pain relief medication through that initially, and IV fluids. So as Richard said, depending on your type of surgery, you may wake up with a drain. So a drain basically is put into the operation site, and it's there to drain all the fluid and the blood around the operation site. It's set on a specific suction, and you wake up with it 1 or 2, or as Richard said, if you get a lumpectomy, perhaps not. This is to assist with the healing and the recovery of your wound. If you're having a longer operation, you might find you wake up with a urinary catheter, but this can usually be removed on the ward once you're up and mobilising. Throughout your stay in PACU, the nurse will assess your classic ABCs, your airway, breathing, circulation, your activity, your consciousness, and also assess your pain, any post-operative nausea and vomiting, and your wound and the drains. When you hit the ward, or in some cases day surgery, you're on the home straight to going home. So the focus here in either of these locations is on adequate recovery and making sure everything's in place for when you leave the hospital. So how long you stay in hospital will depend on a range of factors, mainly your type of operation, how your recovery goes, and also the support you'll have when you go home. Your nurse on the ward will arrange supports when you go home, such as your district nurse, who will come around and assess your wound and your drain at home. They'll also give you an indication of when your next follow-up appointment will be in clinic.
Kylie, there's one little point on your slide that might have some people worried that we haven't covered, which is blue or grey skin. Can you just mention that?
So as Richard was talking about the blue dye, or I think he said particles, that get injected for the sentinel node biopsy, this can cause a discoloration of the skin, blueness or grey colour post-operatively. It's temporary and it might change your urine colour initially as it washes out of the system. I'm not sure if you want to say anything.
No, that's correct, yeah. The dye colour can last quite some time.
You're not going to be a Smith, but you might be blue for a little while.
It does go,
okay.
yep.
Great.
So we'll move on to pain management now. So pain is an individual experience. It very much differs from patient to patient. Ideally, we'd like to wake up with no pain, but it definitely has to be expected. the key around pain management is just making sure it's manageable and tolerable for you. So initially in recovery, you'll be given pain medication via your IV drip, and this will work virtually straight away as it goes straight into your bloodstream. As you move down into the ward and in stay stay, you'll move on to oral pain medication, and you'll also get a prescription to go home with. To stay on top of your pain, it's best to take at home your pain relief as prescribed. That way you're on top of it and you're not playing catch up. So rather than taking it when you begin to feel pain, it's better to take it regularly, first of all, as prescribed. As you get down the track, ideally you'll be taking less pain medication, but if your pain doesn't get better, or if you don't notice it's getting better, or it gets worse, it's good to contact your breast team. You might find numbness and a burning sensation as a result of temporary nerve damage. This should resolve over time, although, as Michelle said earlier, she still experiences some numbness.
Yeah. Around the back.
The numbness will probably be permanent, but you won't notice it so much.
Yeah, it'll get better over time. Some instances, pain can be ongoing, and this can be referred to as chronic pain. Your breast team might think it's appropriate to refer you to a pain specialist team who will help you manage this. So also I'll talk about post-operative nausea and vomiting, which can be quite a worry for some patients, particularly if you're prone to nauseousness. The anaesthetist during theatre will be giving you some anti-emetic medication, which is anti-nausea medication. So ideally when you wake up you won't feel nauseous, but if you do, your recovery nurses can get onto that very fast and give you IV anti-nausea medication. If you find that you've taken tramadol before and you know you get nauseous from it, information like that is handy to tell your anaesthetist or your nurse so they know not to give it to you and they can give you a different medication. So moving on to wound management. Depending on the surgeon and their preferences will differ on how you wake up and what your wound looks like in terms of sutures and dressings. But usually you'll get an absorbable stitches and then steri strips and a waterproof dressing, also known as an op-site. Some surgeons like to use Dermabond, which is a skin glue essentially. You might wake up with a pressure dressing, and this is a firm, tight dressing to help reduce swelling and also reduce the bleeding. This pressure dressings tend to come off pretty soon following recovery. Ideally, keep the dressing on for 5 days, but leave the steri strips intact, and this just helps with the healing and will help with the scarring really. And just avoid putting anything on your wound until it's fully healed, especially when it comes to things like bio oil and deodorant. You're going to make sure that your wound is completely healed. Bruising and swelling is common. That's the normal part of the healing process, and it will resolve up within the first month. But if swelling is still present and you're worried, it's definitely something you need to tell your breast team, or even if you're seeing a lymphedema therapist, that's ideal. Tell them. A seroma, as we talked about this before, is a collection of fluid, and this can occur in the breast, chest, or under the arm. It can cause discomfort and restrict your movement, and at times, depending on the breast team and what they decide, they might choose to aspirate it. So now I'll talk about drain management. Patience is key with this. Your drain, you might go home with a drain, you might not, but if you do, your ward nurse will tell you what to do when you get home, how to care for that, how to empty it and put the suction back on, and also to record its output. Usually it's removed when there's less than 30 mils over 24 hours. In regards to rehab is also very important, but it depends on your type of surgery. If you're having reconstruction, perhaps you'll take a bit longer to get back to your normal mobility. Your arm and shoulder might feel a bit stiff and restricted at moving, so your nurse or your physio will give you key exercises to help with this. As you're feeling like you're getting better and your pain's decreasing and you're more comfortable with mobilising, you'll feel you'll be able to do more, but that's something you should take day by day and as your body feels right. Rest is also important with recovery. Breast Cancer Foundation, we fund 4 one-on-one pink physiotherapy sessions through Pink and Steel, and this is with specialised cancer physiotherapists. We also fund a group Next Steps program, and that's 10 weeks That's also through Pink and Steel. And these programs are both great for rehab and recovery. So I'll just talk about bras and prosthesis. So with a lumpectomy, it's encouraged to wear a supportive bra, but at the end of the day, it's what's comfortable for you. You might find you have an old bra at home and you want to remove the underwire from the side of the operation, and so you still have the wire on your other side for that support. Or you might find it's not comfortable at all, and the drains, if you've got drains, that might not help either. So whatever is comfortable for you. That same goes for a mastectomy as well. If it's painful to wear a bra, then you don't have to. You should be given a knitted knocker, or what we call a softie, going home, and these are lightweight temporary prosthesis that you can put there while the area is still sensitive and the wound's healing and while you've still got drains there. It's important to allow for your swelling to resolve and your wound to heal before you go and get fitted for a permanent prosthesis, and we usually recommend around the 6 to 8 week mark to do this. Natural Wear and Breast Care Products New Zealand are two great companies who have nationwide mobile fitters who can come around and fit you for these. And there's also funding provided by the Ministry of Health for each side, so around $600 for each side over 4 years. So, as I mentioned before, we have a MyBC online community, and I've got some useful tips from patients who have got back to me on there about their experience from breast surgery. So, a lot of them said, be patient, especially with drains. They're in there for a reason, so be patient, bear with them. One lady said she got hers out too early and it resulted in a seroma and that had to be aspirated. Some women think in the shower a lanyard is key, just to clip the drain onto the lanyard so it's not hanging down or you don't stand on it or anything like that. A dressing gown with big pockets to pop your drains in is handy also. Don't always inform your team if you're in pain. Don't put up with pain and be a hero. As I said, it's important to control that pain and make sure that pain is manageable for you. Zonta, apparently the cushions from Zonta are very great to sleep with under your arm or in the car in between yourself and the seatbelt. And also make sure you complete your physio exercises recommended, and ideally, if you can, start the day after surgery, as I've been told. That is about it. Probably most importantly, be kind to yourself. Recovery is gradual. Take time for your mind and body to heal, and if you need, ask for help and use your support network. Support network work will be vital. And that's about it.
Great.
I have.
Yeah. Great. Thank you, Kylie, and in fact, thank you to all three of you. You've been fantastic. We're now going to open up to questions from you guys at home. You can type questions in the box at the bottom left of your screen if you haven't done that already, and we'll get through as many as we can in the time available. So let's just start working our way through those. First up, we've got a question from someone who's saying, it's almost a year since she had a lumpectomy and she's still having armpit, hand and underarm pain. Is that what you would expect after that time?
No, not really. It certainly shouldn't be severe. The nerves are likely that they've been divided or interfered with or even maybe damaged, and it would be worthwhile you should talk to your surgeon about it, and there's probably something that can be done to stop that. But it shouldn't be severe. Generally, the pain is not severe unless you've got a suture on a nerve or something like that, or a neuroma where the nerve can have been cut or damaged, and then it forms a very sensitive point, and it will continue to give pain. Generally, the long-term effect is just some numbness, as we said, dividing the nerves that isn't painful, but you've just got a permanent area of numbness, and you stop. Most patients don't mention it after a while, so just forget about it.
Right,
yeah.
Right. So what sort of treatment would they do for something like that, Richard?
Well, if it was I've had probably a couple of patients where they've had very severe pain, and I went back in and found there was something there to try and do that. That's pretty rare. So generally, if it's chronic, you're looking at chronic sort of pain relief and trying to manage that pain, possibly with injections of local anaesthetic or steroid, and then use of other nerve modulating drugs to try and dampen that pain and get on top of it. But probably, if it's been going on for a year, you need to probably get seen by someone with an expertise in pain, one of the pain clinicians who will be able to help you manage that and deal with it. Chronic pain can be a very difficult thing to sort out, but it is important. Shouldn't put up with it. You should try and get some help for it.
Great. Now we've got a question. I've never been given advice regarding the cording under my arm. It's very uncomfortable, so want to know the best way to treat this. Can one of you explain what cording is, and then that's answer the question?
Go for it.
Cording generally we see after we've done, usually it's often seen after a sentinel node biopsy, more generally after an axillary node dissection, so we see less of it now than we used to. But what it is, it's the lymphatics becoming like little strings of cotton under the arm, very quite firm. You can actually feel these strings. And I was taught by my senior surgeons to break them down, and so you actually break them and massage them down. I think it's done more kindly now than what we used to do by physios. Gently break them down, and they'll eventually, it'll disappear. It will get better. It's important to know that. But it's really an inflammation, I think, of the lymphatics, and so we have all these lymphatics running up our arm and under our arm through the breast tissue, and then like tiny bits of cotton coming and draining your lymph fluid, and they're getting inflamed. And that's exactly what they feel like, little strings going under the arm.
Guitar strings.
Yeah. And you can actually snap them, and the patient sometimes it's quite painful, the patient gets quite immediate relief from that. But often the physios will break that down as well now.
And does it come back, or is it?
No, it generally it will eventually get better, yeah.
Right.
But it's usually in the acute phase, and it probably goes on for about 2 or 3 weeks maybe, so it shouldn't be going on longer.
So Michelle, how long did
I didn't know that I actually had one until recently, and because it was quite deep, and it wasn't until the lymphatic masseuse got right in, and then she could feel it, and she showed me where it was, and it did it just so exactly like a guitar string, basically. So she got it in.
Broke it down.
Yeah, I think she did. Yeah.
So, yeah. And I think we've heard of some physiotherapists using handheld laser for cording too, and in fact we funded a study on that a year or two ago, so that is one option.
Should have used that as
laser
well.
Yes.
Yeah.
No, the little handheld laser. Yeah. So you had that as
yes,
well.
I had that,
Yeah. So I don't think that's widely used, but it is one of the options.
It's also useful to, if you're going to go to your physio or lymphedema therapist to get it treated, get some pain relief on board, because those sessions can be painful, so it's better to get on top of that to make that session a bit more comfortable.
Right, good tip, Kylie. Thank you. So again, take that before you start, rather than when the pain kicks in. Right. Okay. Another question. My plastic surgeon recommended a DIEP or implant as reconstruction options. I chose an implant, but unfortunately it failed due to post-op infection, so my tissue expander had to be removed. As a fit and healthy person, this wasn't something I anticipated. Now I'm on the cusp of perhaps having a DIEP this time. Sorry, this is quite a long question. If I don't have enough fat to use for that, match my other breast, does fat transfer through liposuction work permanently? That's quite a complicated question. I don't know if you're...
that is quite complicated. I mean, it's very sad that your implants fail, but it does happen, and implant losses are well documented, around about 5%. So, yes, I can see the problem there. You're left with the implant will have been removed, and you need to have your own tissue really to use that. So, if you have a DIEP flap, generally they can. Depends on how much tummy you've got really to make that up. So your plastic surgeon will be able to advise whether you're a candidate for that or not. I don't think that having lipofilling to try and make up a big defect would be a good idea. It is possible. There's a bit of controversy about lipofilling, but it's generally accepted that a reasonable percentage of the fat transferred will work. But I would be careful if you're expecting to make up a big bulk of your new breast with lipofilling. If you haven't got enough information from your current plastic surgeon, you can always seek a second opinion from another one about what to do. I think that's important.
Yep, and in fact, fat loss is the target of a study that we're about to start funding here too, because quite a few people do experience some degree of fat loss and end up having further surgeries. So if you're really on the margins, it might be quite tricky. Yeah. Okay. Next question. So back on the subject of numbness, this someone says I'm 3 years post-surgery and still have numbness all around my breast from a full mastectomy and back area. I believe this to be quite common.
Yes. Yep. Potentially all of the nerves run through the area where we've operated, and they will be divided. The mastectomy shouldn't be too numb, but it could be. Sure if you've had a reconstruction or not, but that would be possible, and it may never return. Because if the nerves have been divided, they won't grow back again. They're intact, and then they could recover, but generally, if you've had axillary dissection like you had, you'll have that permanently.
Yeah,
but it's not
come back.
It's not generally something people complain a lot about, the numbness, but it probably does for some people.
Now I've got a question from someone who had 14 nodes removed in surgery a few years ago, now facing a mastectomy on the other breast and worried that she'll lose nodes in that arm also. The first time around the nodes weren't cancerous, and so but worried that should the nodes be taken as a precaution?
No, you should just have a sentinel node biopsy with 1 or 2 lymph nodes removed. And now, as I said, a lot of the time we're not actually, even if they're positive, so we take the lymph nodes out, see if there's cancer in them, and then we used to go on and remove all of the lymph nodes. Worldwide, there's a big trend now just to, even if there's cancer in them, not to do anything more there or give radiotherapy to that. So you probably won't lose your lymph nodes.
Right.
As I said before, we used to remove them all as a routine,
yeah.
14 negative. Well, there's no need to do that. You don't need to do that anymore.
So definitely a good conversation to be having with your surgeon beforehand to understand what. Now a question, what garments do you recommend to wear immediately after surgery?
I wore crop tops.
Is that?
Yeah, I just went to the warehouse and just wore the little crop tops and stuff. There's no wires. It was comfortable. There's a bit of support. But
yeah, so as a bra or as a
top? Yeah, as a bra,
as
a top, basically. Because I was just sitting, it was just around home. Yeah, and I wore this for quite a while afterwards. Yeah, and because it's comfortable and easy to use.
Front fastening bras. Women say they're easy to get on and off, easy to do up, and probably more comfortable, I'm sure. From speaking with breast nurses, by the sounds of things, it's what's comfortable for you at the end of the day, depending on where your wound is, and also if you've got drains initially as well. And then again, if you have an old bra and you just want your underwire out of one side, the operation side, but then want the underwire on your other side to have that support, it really just depends, I think. Is that what, I'm not sure what you
I use a combination of this. I think Eric and I both use these, which are actually abdominal binders, but they're quite good for keeping the pressure on. But also use surgical bras, put them in theatre. And I'm not sure if they actually funded by that.
No, so not at the moment. So I think that's a lot of women do advise, as you say, what you got. People shop around, and I think I've heard other shops as well, H&M and places have comfortable bras apparently. But yeah, post-surgical bra ideally would be great. But they are, I think they're more costly.
A sports bra without the under.
Yeah.
It's like the R bras and things that, that's sort of what I pretty much wore, wasn't that? But they look like that. They were just, basically crop top.
I think, basically something that's comfortable to get you through to that 6 to 8 week mark when you can get fitted properly with by your prosthesis fitter, and then you get your bras with your funding. Then I believe the Ministry of Health funding, you can use that funding for the prosthesis as well as the bras from wherever you go to get them.
Yeah. And as you say, similar to the front fastening bra, things that aren't going to be a lot of difficulty to get into in terms of moving your arms and shoulders and so on, maybe, depending on what you say. Okay. And in terms of lymphedema prevention, what can you do to lower your risk of developing lymphedema?
Yep.
These sleeves. Yeah, the compression sleeves is what I got basically one straight after surgery.
I'm not sure. Are those normally recommended for people who don't have a...
I think it's a good idea. So if you've had an axillary dissection, you had a lot of lymph nodes removed, really. So it's a good idea to wear that preventively. And certainly working with you, you haven't got your rings on there, no problems with any lymphedema. So it's a good idea. But for the majority of people who are just having sentinel node biopsy, the rate is low. But you should avoid any infection in the arm. Try and, if you get an infected scratch or something on your arm, you want to get treated pretty quickly. That's mainly for people who've had axillary node dissection, though. Because if you've had a sentinel node biopsy, it's generally 1 or 2 lymph nodes, and the rate of lymphedema is not that high.
Because it develops in stages, so just early detection is key. Yeah. So if you're worried, if you notice swelling, you notice your clothes are getting tighter, your jewelry is getting tighter, any slight sign is worth getting checked, or just to make sure, because early detection, you'd rather detect it early. And
a lot of the breast clinics now probably have a measure your lymph. You can do an impedance measure of the lymphedema.
Is that something you should ask for? If it has
you could ask for that. Right? If the clinic has it, I'm not sure that every...
No, quite a lot of the clinics do. We've given them to a lot of the hospitals around the country, and I guess that gives you a baseline to tell you. And
it's a proper measure. You come back and you can have it again.
Technical,
so if you see it starting to get on, then you get on to try and stop it early by wearing a sleeve. And also physiotherapy is important too. The physiotherapists play a huge role in this area.
Right.
And our physios see women post-operatively as a routine, even if they had sentinel node biopsy, just get the Atkins exercise and arm movement.
Right, so exercise.
Because they need to do that base before you have any surgery or anything else. They'll take that base reading. Yep. And I know mine was 5.2, and then after chemo and everything else, I went up to 11.5. Right. So the next one down, I've come back down to about an 8, I think it is. But anything over 10, they get a little bit worried about.
I think that's good advice, Kylie. Any little changes get noticed right away, because once lymphedema sets in, it can be quite hard to
The Lymphedema New Zealand website is really helpful. It's got a list of all the therapists in your area, and also it provides the contact details. So if you wanted to give them a call and just say, I've got this symptom, or an email, that could be very useful as well, just to have that direct contact with them.
There's some very good physios specialising in lymphedema.
And in terms of getting access to the Pilates and the next steps so on, Kylie, can people give you a call, or how does that?
Yes, you can feel free to call the advice line. You can message the nurses on MyBC, or you can also email us a breast nurse email. So from there, we'll let you know how to apply. There's a bit of criteria, but so that's all part of the application, and then we'll get back to you. And then the voucher entitles 4 sessions. It's one-on-one with the physio, and so that's great for rehab and also for the whole prevention and of lymphedema too.
Great. Another lymphedema question. If you have lymphedema, is it best to avoid having your blood pressure taken on that arm and also blood tests?
Yeah.
So even just taking your blood pressure is not a good idea?
I don't know the exact. You're best to avoid that.
I guess you've got 2 arms. You might as well use
the other one.
We do have some pink silicone bands here that we can, if you wanted to wear one, you can. And it's just it's a reminder. Some women like to wear it because they forget when they go to the GP. It's also useful for in the hospital as well. They have paper ones that pretty much they stick on you in the hospital. But our silicone bands are pretty useful as well. There's no BP and no needles, I think, no blood taken.
Right.
Yeah. These blood tests very
important. Do we have any more questions there on your side? No? Okay. another question that came in a bit earlier around preparing for surgery. Is there anything you can do to get yourself in better shape for breast surgery, or you just roll up and...
Well, if you're a smoker, stop smoking because that's important for just, you're going to be on a ventilator when you're having your anaesthetic, and then you don't want the lungs getting chest infection. So stopping smoking is always a good one. But, just try. I don't think there's anything special you can do. Just do everything you would normally do. Don't do anything to excess beforehand.
Good tip. Great. Okay, well, I think that's it from all of you at home. Thank you for joining us tonight, and huge thanks again to Michelle and Richard and Kylie. You've all been fantastic. We hope you all found this helpful, and we'd appreciate if you have a moment, if you wouldn't mind filling out the exit survey as you exit the webinar. That would just take a minute. If you have any questions resulting from this webinar or about anything else, Kylie and our other nurses will be available on the phones tomorrow on our 0800 BC nurse line, and that number will come up in a moment. They can provide referrals to our free counselling and to the next step and the Pink Rehab services, and can also help you connect to MyBC, which is our online patient community. That's where Kylie shared some of those tips from earlier, and that's a great place for patients to hang out together. You can find MyBC in the App Store or look at it online at mybc.care. In the next few days, we'll send you a link to the recording of the webinar if you'd like to watch it again or to recommend it to someone else. That's it from us. Thank you again, and we'll see you next time.